Good evening, everyone. I welcome you all to the series 48 of the CAHO-ISQua International webinar on the topic of AI. AI, the burning topic of today, and the topic for us today is how AI will transform health service delivery and how will accreditation help the leverage to leverage the opportunities and address the challenges. We have with us today Dr. Carsten Engel. We are really honored to have him. He's the CEO of ISQua, an eminent leader of the worldwide healthcare, who will take you through this insightful discussion on how AI is revolutionizing healthcare delivery and the pivotal role which accreditation plays in maximizing its potential. Our moderator for today, I welcome you, sir, is Mr. Rajarajan S. Is the Group CEO of Ashram Hospitals and a distinguished member of the CAHO International Forum. He will guide the session and facilitate the conversation of this important topic. AI is a burning topic of today, and I think the most transformation it's going to bring is in healthcare. That's what we feel, though it is affecting every wake of life today. It does this by improving efficiency, accuracy, and patient care. However, to fully harness its potential while addressing challenges like data privacy and regulatory concern, accreditation is the key. Accreditation ensures that AI tools meet safety standards, they adhere to ethical practice, and integrate seamlessly into healthcare systems. It builds trust, promotes collaboration among stakeholders, and ensures that AI innovations align with best practices, ultimately enhancing healthcare delivery while safeguarding patient interests. And today, it's a CAHO-ISQua collaboration. And as you know, CAHO is consortium of accredited healthcare organizations in India with the primary goal of enabling quality initiatives in Indian healthcare settings, which is being done through focused events, courses, workshops, and training programs. And our moderator for today, I welcome you, sir, Mr. Rajarajan S, who's a Group CEO of Ashram Hospitals, Eluru, Andhra Pradesh. He's a seasoned healthcare thought leader and a turnaround specialist with a global perspective and a strong business acumen. He manages the NABH, NABL accredited 1,300 teaching hospitals and also a 390-bed state-of-the-art Ashram super specialty hospital in its project phase, commissioning from October 2025. He has successfully led ventures in multi-specialty care, oncology, cardiology, diagnostics, and digital transformation. He holds key accreditations such as JCI, NABH, TOAI, a distinguished fellow of AHPI, member of the American College of Healthcare Executives, and Telemedicine Society of India. I welcome you again, Mr. Rajarajan, and over to you for the program.
Yeah, thank you very much, sir. So I would like to take the privilege of introducing with us our special guest for the day. Very happy to welcome Mr. Dr. Carsten. He has obtained an MSc in Physics and Chemistry and an MD from the University of Copenhagen, and subsequently he has earned the board certification in anesthesiology. In 2006, after a hospital career spanning 22 years, including a period as Chief Medical Officer, he joined ICAS, the Danish Institute for Quality and Accreditation in Healthcare, where he was appointed Deputy Chief Executive in the year 2010. In ICAS, he was a member of the team that developed, implemented, and managed the National Danish Accreditation Program. In 2021, he joined ISQua and ISQua EA as the CEO. He has been a member of the ISQUA's Accreditation Council between 2010 to 2021, Deputy Chair since 2016, ISQua Expert since 2013, He has contributed to the development of ISQua's international accreditation program and is a member of the ISQua Academy of Quality and Safety in Healthcare since 2019. He has published and presented on accreditation related topics. It's such a pleasure to have you, sir. Over to you, sir, to take us through this wonderful session on AI will transform healthcare service delivery.
Thank you, Dr. Nareen. Thank you, Mr. Rajarajan, for the kind introduction. I will now share my slide. Good afternoon and good evening to all of you. It's a pleasure to speak to you today on this interesting and important topic, and I bring to you the greetings from the entire ISQua community. Oh, sorry about that. There was a little technical problem. I think I will open the presentation once again. I'm sorry about that. So we'll give it another try. I'm sorry about the problem. Okay, so before I proceed, I want to make a declaration. First, I used ChatGPT-4 when I prepared this presentation. And secondly, I take responsibility for what I'm saying. What I say are my statements, not ChatGPT-4's. And by doing so, I illustrate two important and fundamental principles for the use of AI in healthcare. And those are transparency. Everyone we work with, colleagues, partners, patients, and families should know when, how, and for what purposes we use AI. And the second is that accountability always rests with the humans. And by the way, this is also reflected in the position of many leading peer-reviewed journals. You can use AI as a tool when you prepare a paper, provided you declare it, but an AI can't be listed as an author. I believe it's useful to begin with a brief outline of what AI is, and I will illustrate with examples related to large language models such as ChatGPT. It's on a very high level as I'm no technical expert. However, it has helped me understand the nature of the opportunities and the limitations and the challenges, and I hope it will help you as well. First, an AI is based on a neural network architecture. The training process is very important. There are issues about data and knowledge, about operational use, and about limitations. And let's take these bullet points now one by one. First, neural network architecture. Large language models are built on neural networks, which are algorithms modeled loosely after the human brain. These networks consist of layers of nodes or neurons that process input data, such as sentences from books, articles, and websites, to learn patterns in languages. There can be different kinds of algorithms. There can be rule-based algorithms, such as if A, then B, but there are also probabilistic algorithms, if A, then B with probability X%. What's important to understand is that these algorithms are not programmed into the large language model by design. The large language model learns what the rules are during the training, which in turn means that it may not be obvious to the user what these algorithms actually are. And about the training process. During the training, the model is exposed to a large, or I would say a very large corpus of text. It learns to predict the next word in a sentence given the words that came before it. And this process involves adjusting the weights, the parameters of the network based on errors in its predictions. So it tries to propose an algorithm, it tests it, and it learns from the comparing the algorithm with the real text, the real corpus it learns on. So how does this actually happen? Well, ChatGPT-4 is said to have been tested on a corpus of something like 10 trillion words from a diverse and extensive range of sources, including, but not limited to, books, websites, academic journals, news articles, Wikipedia, forums and social media, technical manuals and documentation, fiction and nonfiction. And all of these sources will help to ensure a well-rounded training that encompasses a variety of writing styles, perspectives, and knowledge domain. But it's important to notice that ChatGPT only has limited access to real-time information or proprietary databases. And as of the 10th November 2024, when I last checked it, ChatGPT-4 was last updated in October 2023, but it can use web searches to find the latest information. But you will notice that there is a certain delay from the point of training and until now that you need to be aware of if you use AIs. Other types of AIs may be trained in different ways, but the principle is the same. You are trained on something and you then learn to predict pattern based on what you learned during that training. I don't think we can say that a large language model understands text in the human sense. They develop a kind of statistical understanding based on the frequency and the context of words and phrases they encounter in the training data. And this allows them to generate coherent and contextually appropriate responses. But I mean, when you interact with ChatGPT or another large language model, as I assume many of you, if not most of you, have tried to, you will get astonished by the human touch of the way it responds to your questions and suggestions. Once trained, you can use the large language model for various tasks such as translating languages, summarizing texts, generating creative writing, or even answering questions. It operates based on the patterns and informations it learned during training and does not learn from new data unless it undergoes another round of training. So this doesn't mean that they are pre-programmed in a, let's say, in a strict way. They can perform tasks that are not explicitly trained to do. I'll show some examples in a moment, and they will provide answers to questions the engineers had never thought of when they designed and trained them. One limit to the actual use is that you can only use them to process text of a limited size, and for ChatGPT-4, this is on the order of magnitude of 4,000 words. It's important to notice that a large language model does not possess consciousness or actual understanding. The responses are generated based on patterns and data, which can sometimes lead to inaccuracies or biased outputs if the training data contains such flaws. And to quote CAHO-ISQua, and a large language model can generate texts and images that are convincing, but that's not the same as being correct, safe, and grounded in scientific evidence. And obviously, this is something that LLM designers are working hard to improve, but the model will identify a pattern. It will not test this pattern against reality. A hedge fund manager, actually, Ray Dalio, expressed what an AI does in this way. It has an enormous capacity to see past patterns and process many ideas very quickly. It has little or no common sense. It has trouble understanding the logic behind relationships, and it doesn't have emotions. It's simultaneously smart and stupid, helpful and dangerous. It offers great potential, and it needs to be well controlled, but not blindly followed. Well controlled, not blindly followed. That's what I said to you earlier about human accountability. So it finds pattern, but does not fact check them. It does not check whether they make sense. It does not address underlying reasons for why the patterns are as they are. And what's the difference between seeing a pattern and understanding the underlying reason? And I can illustrate the point with an example from another domain, astronomy. Kepler, a 17th century astronomer, the one who discovered the way the planets move around the sun. If an AI had had access to Kepler's data, it might have been able to recognize that the planets move around the sun in an approximately elliptic trajectories, but it would not be able to realize that this can be explained by a gravitational interaction between the sun and the planet that is proportional to the product of their masses and inversely proportional to the square of the distance. It can see the pattern, but it's not able to realize why the pattern is as it is. And again, what it looks for is determined by the corpus it was trained on. That means that if that corpus is biased compared to reality, we want to apply the IA on, then its ability to recognize patterns will inherit this bias. So it's very important to ask yourself when you have an AI application, when you offer to use an AI application, how was this AI application trained, and does it correspond to where I want to use it? So now I'm trying to give you a brief outline of what an AI is. And you should, of course, be aware that before we explore the possible use of AI in healthcare, the box of Pandora is open already, and there's no way of closing it. Generic AI, such as the large language model, they are readily available to virtually everyone, including you, your bosses, your staff, and your patients. Some are available for free. For some, you have to pay some subscription fee, but they are there and they're used. They're generic, these large language models. They are not designed for use in healthcare, but they have an immense healthcare knowledge and insight. And of course, I use this word between quotation marks. But nevertheless, they produce text that appears to reflect just that knowledge and insight. And you can rest assured that you will encounter both patients, or you probably have encountered both patients and professionals who already seek advice from ChatGPT and the other available large language models. Sorry. Patients can use them to get advice on self-care. They can use them to prepare themselves for a medical visit, or as a cheap and easy way to get a second opinion. And professionals can use them as a huge knowledge bank that's very easily accessible. Here is an example of a question someone might ask, and the answer that ChatGPT-4 gave me when I asked it. I haven't displayed the entire response, but you will see that it discusses benefits, risks, considerations, alternatives that are very relevant to the question I'm asking. I suppose I acted as if I were a patient, saying I'm somewhat overweight. I don't care to mind about diet and exercise. Should I use semaglutide? And you will see the answers. I won't read it out to you. And well, it is a very sensible answer, but also note that it refers at the end to the healthcare provider. You must go to your healthcare provider to weigh the benefits and risks and make an informed decision. In this case, I asked as if I was a lay person. I also tried to ask the same question as if I were a physician preparing for a visit with patients. And you can see that everything is now expressed in medical language, and also that you are almost provided with a script for the examination and discussions. And notice here one of the interesting powers of large language models. It provides me with a suggestion for a counseling script to use when I meet the patients. That was not something I asked for, but ChatGPT seems to have thought that I might find this useful. So it's not just a huge knowledge bank, it's also a tool that can help the physician formulate the knowledge, the advice, the messages in a way that's easily understood by patients, something that can sometimes be a little bit difficult for a professional who is prone to speak in professional language, in a professional language. You will have to check the advice before it's given to the patient, but I think it will reduce some of the more tedious workload of a physician considerably. You will also have noticed how the model is able to emulate empathy. It's as if it's a concerned human is talking to you. This is a very simple example, but it may make you think of an LLM as an all-purpose clinical guideline. But there is a very important difference between a large language model and a clinical guideline published by a professional society. In the latter, every word is checked and double-checked before it is released. However, it's impossible to check in advance how a large language model will respond to every conceivable question because the number of possible questions is unlimited. The response depends on details in the way the question is formulated, and due to the statistical nature of the way in which it works, the answer may not be the same even if the same question is asked twice. For instance, when I asked the same question again a few days later, it didn't give me a counseling script. And when I asked it then for a sample script, it didn't create a script like this, but created a script of a dialogue between physician and patient. So there's an element of randomness in it, which makes it impossible to control completely. But now we will move on not to talk about large language model, but about dedicated AI-based tools. And they, of course, offer a lot of opportunities. And here just list a few of them. Early detection of sepsis. Well, this is something that clearly depends on an ability to recognize patterns. And there are tools out there like the early warning scores that can help humans find and identify these patterns. But nevertheless, there are some studies suggesting that at least in certain settings, certain AI tools outperform humans in that respect. There are also tools that can facilitate the reading of diagnostic images, and the main advantage here is actually speed. I saw one study where this was a study of chest X-rays, and the aim was to detect 14 pathologies. 420 images were reviewed and examined. The algorithm took 1.5 minutes to do this. A radiologist, 240 minutes. 240 minutes. But then what about the performance? Well, in 10 cases, the algorithm and the radiologist were equivalent. The IA was better for 1, but it was worse for 3. So it's something that can help you do a lot of screening in a short time, but you can't eliminate the human final factor as of yet. Rare diseases, this is also an issue of recognizing patterns. As you will all know, we humans are most likely to recognize this pattern we have seen before. It's more difficult to recognize patterns that we have only read about in a textbook or heard about. This limitation is not inherent in an AI. It doesn't forget anything, which also means that it can protect against loss of information along chains and between silos. And for health status monitoring and alerting in general, not just for the early detection of sepsis, but in general, there's a huge potential. And just imagine what you can do with wearables nowadays to help patients do this kind of monitoring themselves and contact the healthcare providers when there is a need for it. But with all these opportunities, then what about empathy, trust, and kindness? AIs are quick learners, and they become better at passing exams. And you can also they can also express themselves in empathic ways. There's one study that found that whereas ChatGPT to a certain set of questions provided empathic or very empathic responses 45% of the times, humans did so only 4.6% of the times. And what's the explanation for this? I mean, the chatbot was designed to emulate empathy, obviously, whereas physicians may consciously or unconsciously have understood the task as giving a precise, factual answer. But nevertheless, I believe that expressed empathy is one thing. True kindness also involves that you see a fellow human who is really concerned about you. Yeah. Yeah. Evidence-based care. This is also an area where we can find help from AIs. They can, for instance, help us find a relevant randomized trial which explored a study population into which the patients we are now concerned about fits. And there are AI tools that can suggest individualized care in complex cases based on a large corpus of clinical experience. I believe the Mayo Clinic is one that is trying this kind of tools, for instance. It can be a powerful physician's assistant, summarize notes in patients' records. It can even listen to conversations and create notes from them, prepare drafts for responses to requests from patients, and it can even be used as a tool to create a curated Q&A sessions for patients and professionals. It can plan and optimize flows, and it can help patients. Healthily is an app that was designed to guide the patient's journey to seek the right appointments given the problem you want to seek help for. And it was demonstrated that it would be able to reduce waste by eliminating some kinds of visits that the patients might have wished to do, but was not really the visit that was relevant for the case. And patient safety can be revolutionized. In this perspective paper, you see that an we can use artificial intelligence to review patient records. It will reduce the workload of reviewing patient records, like we, for instance, do when we use the trigger tool, the trigger tool tools and things like this, and it will enable you to detect and enable errors in real time, or at least in timely enough to be able perhaps to correct them before they progress to harm. So when it then comes to regulation, we need to define some legal aspects of the use of AI. We need to define the basis for approval of an AI tool. An AI tool is like a drug or a medical device, something that needs approval before you can use it on patients. And what's the basis for this? It must be based ultimately on demonstrated benefits for patients in terms of outcomes that really matter. But there are other legal issues that we need to consider as well, and that's the issues about accountability. What is the accountability for a professional user using an approved AI-based tool? What if you use a generic tool? What are the consequences of adhering to the advice given by the AI? And perhaps just as important, what are the consequences of neglecting the advice, doing something else? And what level of autonomy can you give to an AI? Can it make suggestions? Can it make recommendations? Can it even make decisions? All of these questions need to be answered before you put AI into actual use. And again, one difficulty in this is that for a traditional medical device, such like a ventilator or an infusion pump, you can describe its possible actions and you can base the approval of an assessment of the processes that it can, of more or less exhaustive map of the processes under which it can operate. But you can't do that with an AI because we have seen you can't describe all it does. We can describe how it's created, but we cannot describe in detail all of the things it does. Ethical challenges. There are challenges with things such as data privacy and security concerns. There can be bias in AI algorithms, and there are issues of fairness. Does everyone have the same access to these tools? You need to ensure equitable access to AI tools, and there's also the issue of alienation or perhaps also empowerment. Some people will be alienated, feel alienated by seeing an AI somehow interposed in the relation between patient and healthcare provider. But to other patients, the AI may enable them to take more responsibility for their care themselves. In other words, some kind of empowerment. Trust. Can you trust an AI? Some scholars talk of the trust triangle, and this is one version of this trust triangle. We may believe in the logic of the AI, and it's probably the case that in some situation that logic outperforms the logic that humans can provide. But can it be authentic? Or can I believe that it cares about me and my success? It can be able to emulate much of this, but this is not a fake. Well, for the moment, considerations like this, and also, of course, the accountability issues, need me to believe that AI no doubt will be an extremely valuable enhancement of the human care provider, but hardly, hopefully, a replacement. But it will change the way in which we interact. There will be an opportunity to create more time for the human component of our interaction with the patients. And the training will be of healthcare professionals will be less focused on memorizing a lot of facts and more of making sense of these facts. But because that will be the role of the human healthcare provider, to help the patient make sense, to help to make sense of the options that are available, to help the patients make the right decisions in cooperation with the physician. And in this way, AI also will enhance the person-centeredness of care delivery, which is another important quality aspect. It was recently pointed out in a perspective paper in the JAMA that an AI can't worry about patients. They won't have second thoughts. The point was illustrated with an anecdote about a cardiologist who heard a soft click when listening to a patient's heart, but in the interest of choosing wisely had decided not to order an echocardiogram for this otherwise low-risk man. And this is what we should do. We should avoid over-investigating, over-treating patients. But she had some worries overnight about the decision which led her to order and test after all, and it revealed an aortic valve in need of surgical repair. The issue, the medical issue, I don't want to go deeper into this, but it's a known problem distinguishing a benign split first heart sound from a bicuspid aortic valve creak, which is difficult. And I don't know whether an IA would be better than a human to make that distinction, but that's not the point here. The point is that the human can have second thoughts. Did I make the right decision? Not only the statistically right decision, but also the morally right decision. In other words, a human can have an ethical considerations. An AI can't do that. Now a little bit to the division of work between regulators and accreditors. The role for regulators would be to determine whether a given device is fit for purpose, and also to ensure that we have clarification of the legal aspects of use I talked to you on before, including, importantly, the use of generic AI, because people will use AI, also AI that's not designed or approved for clinical purposes. Accreditors, their role would be to ensure the implementation, that AI is used based on safety and quality practice standards, used in a safe and way, and in the way that ensures that we will deliver care of good quality. This I have alluded to already, but some of the things we should address is how was it trained, how is it kept updated, and how do we how do we protect privacy? And this is not just during the use, but also during the training, because one obvious way to train an AI to understand patterns in the patient population you are serving would be to train it on actual data from your patients, from the accumulated patient records, if you like. Can we do that? Well, there's a privacy issue in that. There are ways coming around it, though. One is the use of synthetic data, artificially generated data that mimics real patient data, but does not correspond to actual individuals. This means that we create a population that has the same properties as your population, but is not composed of identifiable individuals. And this allows us to train and play and simulate all kinds of things using AI without privacy issues. So this is, I think, a very interesting tool. So now over to ISQua and ISQua EA's, the ISQua External Evaluation Association's role in accreditation, and what considerations we have about the use of AI. The ISQua EA was established in 2018 to deliver the external evaluation services by ISQua. Its primary program is the International Accreditation Program that delivers unique global accreditation service to health and social care external evaluation organizations and standard developing bodies. In other words, in ISQua, we do not accredit healthcare providers, we accredit those who accredit healthcare providers. In other words, we assure you that you can trust your healthcare provider and that your patients can trust the accreditation you refer to. And we have 3 programs. One is about the standards accreditors use. Another is about the surveyor training program they apply to train their surveyors. And the third is about their own operations as an external evaluation organization. And as you can see, we are present in a lot of countries, 70 organizations from 37 countries around the world, and India is one of the countries where we have several accredited ISQua EA clients. Digital health will be a focus area for ISQua-based accreditation in the future. We have just finalized and will, in the beginning of the new year, release the 6th edition of the Principles for Healthcare Accreditation Standards. These are the standards that, or the principles that govern how your accreditors' standards are developed and what they should address. And they should address in the future something about digital health and AI. But you should be aware that accreditation does not provide technical guidance, usually. It relies on statutory rules regarding privacy and data sharing, etc. But it serves, and the value it adds is about ensuring good digital governance, good AI governance. And what are the actual requirements we would have then for the, not for you, but for the content of the standards you are accredited by? Organizations should be required to have a documented strategy for the assessment, costing, implementation, and ongoing management of digital systems. You should have a process to ensure that the use of digital care does not disadvantage patients, service users who are not able to use digital services or do not have access to the internet to facilitate use of such approaches. This is very important because there will be any hospital, any healthcare facility will have these kinds of patients. They should have provisions for them to get good care as well. But they will actually be likely to have freed resources by using these AI tools where they can be used to advantage. The standards will also require organizations to have access to technical expertise to support effective use of digital health care systems and AI systems. They should be introduced and managed in accordance with any national or regional legislation or regulations where they exist. And if they don't exist, then based on available guidance for best practice. The standards should require organizations to monitor and evaluate the use of AI systems to deliver safe, high-quality care with mitigation of any unintended consequences. And finally, the standards should require organizations to consult with staff delivering care before they introduce any AI systems to understand the practical implications and staff training needs. This is very important. You can't just give these kind of tools without considering how will it affect the organization. And there should be accountability arrangements for all care and treatment delivered with support from AI systems. And patients should be informed when aspects of care are delivered with the use of AI systems. So, if you sum all this up, what we say is that a hospital needs to have a digital health governance mechanism, where governance means setting the direction and framework within which the hospital operates. There should be long-term goals and aims, oversight, and accountability, including accountability for meeting ethical and legal standards. Framework means what tools and methodologies will we use, for what will we use them, how will we ensure that we use the same safety and create real benefits for patients, how will we engage and involve stakeholders, and how will we determine and meet the needs for training and support. Some say that if you know the why, it's relatively simple to find the how. In this case, governance is defining the why and frame and support people to enable them to find the how. But in a field that's developing so rapidly as AI is, it is not possible here and now to define what the how is in a set of standards that may be in use 5 years from now. You may ask yourself whether these standards are too vague and high level. Well, again, these standards are not the standards you will see as a healthcare provider. These are the standards we use to assess the standards of your accreditors, so they can add more specific advice that's suited to your country, your legislation and the type of services you are expected to provide. Our principles are universal. They're used all around the globe in all kinds of settings, but they allow your accreditor to be more specific and more helpful, if you like, when it comes to guiding you. We have already talked about the potential of AI to improve patient safety, and there are other care quality dimensions, of course: effectiveness, equitability, cost efficiency, and timeliness. They are all domains where data collection and data analysis are important for us to understand both where we are and how the quality is influenced by the interventions we do to promote it, when we follow if our interventions have the effect we expect them to have. The pattern recognition and the data analysis capacity and capability of an AI will make it much easier to utilize this data in real time. Person-centered care is not exactly the same as personalized medicine, but one of the outcomes of person-centered care is that medicine will be more personalized, and again, we can be more personalized by being able to learn from patterns in big populations, and we can perhaps also understand person-centeredness better by analysis of patterns in feedback and complaints. So, here are my final points from today. First, AI is there already also in healthcare, and we have only seen the beginning. We rely on robust regulatory mechanisms and good governance systems with providers, and accreditation can support the development of these, and in particular, the good governance system with providers. And by doing so, accreditation can help building trust. Dr. Nareen actually alluded to this in his introduction to this session. It can help building trust among service users and staff. And AI has, of course, a great potential in addition to support quality management by helping us utilize data in entirely new ways. And my final word is that there will be much more about this in the ISQua conference in Sao Paulo in October next year, where the topic is inclusive health systems, navigating challenges with technology and humanity. And I hope to see some of you there. And with this, thank you for now.
Thank you very much, sir. It was a very thought-provoking session. You started very nicely with that disclaimer, and you took us through the limitations of the AI things, AI tools, AI for diagnostic safety, AI and ethics, physicians, assistant. The big question is about the digital literacy in a country like India and the digital adoption that many of our physicians or the teams are ready to take. You took us nicely through the bias, also about the data. You touched upon, like how we are currently also having a lot of training and updating of data, which probably is not the structured data. And this unstructured data or these, without data sanctity, the information which gets into and which is sought by the AI and brought out whenever we use AI tools is always a question. AI is there, but humans are smarter, so we need to really take the right things and take it forward. You took us very well nicely on the legal aspects, also from the regulatory aspects and the accreditors aspect. Thanks again for letting us know the digital health focus. So we are happy that even in our country, the digital health aspects and the accreditation has started. We'll be aligning to the greater goals that you had mentioned. Definitely, the paper that you had shared is something which I would like to definitely, and most of my friends who have attended today would like to read upon in detail how we can revolutionize patient safety with AI, with the potentials of NLPs and LLMs. The trust triangle is something new for us, and a lot of my colleagues would appreciate the learnings out of it. And yes, we are together with you in looking forward to a safe, effective, equitable, cost-efficient, timely, and patient-centered care. So we have very interesting questions. So I'll take up on some of the questions. Okay, there is a disclaimer even on the question. First up is from Dr. Richard Stanley. How do we legally ensure pinpointed accountability when AI tools provide incorrect or harmful advice in critical healthcare scenarios that cost the life of a patient? So when we use AI and it leads to, a matter of life and death for a patient. So what's the take for us on it? Yeah, your thoughts, sir.
Well, it brings me back to what I said about the AI having no. What we as healthcare providers must add to the advice given by the AI is our common sense and our understanding of the situation and what it means. And it brings me back to, I mean, you can actually you have in some way you have the same situation with clinical guidelines, albeit not so put on the edge. I mean, I've seen when I analyzed in my past adverse events, I saw some bad stories where people were doing things they didn't really understand just by following a guideline. So I think one important thing is that we should never allow we should never allow anyone who doesn't understand what he or she is doing to act with patients just based on the advice from an AI. It gives you advice, but the advice has to be processed by someone who understands the situation before it's translated into action.
Yeah. Thank you, sir. So we need to be wary of the implication. It is the human who are implied, and it's our common sense that has to prevail, even while AI is suggesting. So ultimate responsibility is with the human. The next question is will there soon be an accreditation for AI platforms to find its compliance to medical use readiness? Question from Mr. Arun Govind.
Well, the kind of accreditation, I mean, there are many accreditation can be used in many areas, but the kind of accreditation we are working with in ISQua, that's actually not so much about the technical the technical properties of a tool, but of the governance aspect of using it, as I said to you. But obviously there is a need for creating mechanisms, be it accreditation or regulations or whatever you might call it, to ensure that we who use the tools, and obviously can't be technical experts in everything, can trust them.
Yeah, so the adding on to your thing, if you are using AI tool as a risk prediction tool, you need to get it registered like a medtech device used for diagnostics. In many of the countries, these have now started. So now once these regulations are there, for those regulations and how we are utilizing, accreditation standards would come by. Just adding to
And
your
there's actually a gray zone between using AI tools to analyze data to predict risks for patients, and let's say a more quality management approach where you use it to understand risk for the system.
Yeah. So we have a couple of questions from Andre Basualdo Allende. I hope I got your name right. So great presentation. I would like to ask, in your opinion, should the clinical informed consent be mandatory in medicine and dentistry, and also for training of AI models in both? If yes or not, why?
there must at least be clearly legal frames regarding that. But I think I'll again take an example from another area. In my home country, Denmark, we have clinical registries where we collect data from patient treatments for quality study purposes. There is a special law that allows healthcare providers, actually requires them to provide this data without the need for informed consent in each case. But there is a very clear framework then for how this data can be used and for what purposes and by whom. And I assume if we go to AI, it may be not feasible to get the informed consent from everyone that contributes for a database. But then there must be a really clear framework that defines exactly how we can use it and that is able to be trusted by the people who actually, in the first instance, provided the data.
Yeah, one more question from the same person was he's an assessor from Chile, and they wanted to know how they could actually get the ISQua IEA accreditation so that they could become an international accreditation surveyor. I think that's a very personalized question. So they can write to ISQua through the website, and the team from the ISQua would help
then we
it
will
further.
provide more info. Then we would provide more information. Yes.
Yeah, Arun Govind has further asked about, like HIMSS MRAM model for electronic medical record adoption. So for AI, would something be on the offering in the future? So we have level 1, level 2, level 3, level 4, level 5 models as per the HIMSS for various HIS tools that we're using and stuff. So for AI, do you foresee something like the MRAM model coming in and becoming the gold standard in the coming days?
It's difficult for me to say, but I mean, we should have a systematic approach to this, and such a framework might be a good support for that. Yes.
Yeah. Thank you, sir. You've been very patient and have given us a very good insight into today's topic. And you were also taking us through these Q&As, which has come from people around the globe. So we did have many international people around as well. So thank you very much for joining us on this yet another CAHO-ISQua webinar program. And over to you, Sarin, sir.
So thank you very much, Dr. Carsten, for such a wonderful and enlightening session. And as a mark of appreciation from CAHO, we would like to hand over the certificate to you, sir. This will reach you in a while, but till then, please appreciate this and accept it as well. Thank you very much for moderating the session so wonderfully, Mr. Rajarajan. And it was a really nice insight. Thank you very much for this wonderful session and a wonderful evening. Have a great evening. Thank you.